Okay, so let's continue with the menstrual disorders. So, in menorrhea, we have primary menorrhea and secondary menorrhea. Primary menorrhea is basically what females go through by the age of 14 years, as they have no secondary sexual characteristics, and by age 16, there is the secondary sexual characteristics. So, by then, menstruation is set in. Primary is those growing up who have not reached the age of puberty yet. Secondary amenorrhea is absence of menstruation for about 6 months. That's 3 times the menstrual interval. The causes has to do with the hypothalamic pituitary ovarian axis. So disorders of the outflow tract, disorders of the ovary, and the disorders of the hypothalamic pituitary axis. So, amenorrhea, those are the outflow tract. So there could be cryptomenorrhea, absence of hypoplasia of the vagina, testicular feminism, or feminizing syndrome, Asherman syndrome. All these could cause amenorrhea. So disorders of the ovary, it could be Turner syndrome, gonadal agenesis, and resistant ovarian syndrome. So premature menopause as below 35 years. So amenorrhea, for the disorders of the hypothalamic pituitary ovarian axis, there could be hyperprolactinemia, weight loss associated with amenorrhea, also Kalman's syndrome. And basic investigation, you just first start with your history, your investigations, including the and then you add BMI to it. And general investigations, you do an abdominal pelvic ultrasound scan, hormonal assays, prolactin, FSH, LH, TFT, androgens, also progesterone challenge test. And you could also do a diagnostic D and C. For oligomenorrhea, that's the occurrence of menses fewer than 6 times in a year. It could be from polycystic ovarian syndrome, androgen producing tumors like ovary, adrenals, ovo testes, and also drugs like danazol, androgens, um, di- diazoxide, and also phenytoin. All these can cause oligomenorrhea, and then endometrial problems too could cause it, and idiopathic conditions too could lead to oligomenorrhea. For menorrhagia, that's excessive menstruation. Um, the normal is between 21 to 35 days, and the duration is from 2 to 7 days, and the blood loss is about 36 to 40 mils. So excessive loss, as measures that's too long, too frequent, too heavy, or too irregular. Menorrhagia is basically above 80 mils of blood loss. The causes are physiological, could be dysfunctional uterine bleeding in 60% of the cases, and also uterine tumors, for example, submucous fibroids, endometrial cancer, chronic PID, pelvic inflammatory disease, endometriosis, and ovarian tumors. Um, hormonally active tumors like granulosa cell tumors could lead to menorrhagia, and IEDs too could lead to menorrhagia. So the basic investigation, the history examination, including the also investigations like FBC clean, hormonal, for example TFT, E2, EU, and an ultrasound scan, DDNC too could be done. And the management is conservative, like giving NSAIDs, add mefenamic acid, tranexamic acid, combined oral contraceptive pills, progestogens, danazol, depo-provera injection. And also, it could be surgical endometrial resection, endometrial ablation, myomectomies and hysterectomies, and also irradiation is normally not used. So, iatrogenic cases too. And dysmenorrhea basically refers to pain associated with menstruation. We have primary and secondary. Primary, there's no organic cause, and typically it commences few hours before or at the onset of menses and lasts 2 to 3 days, but ends well before the menses. But for secondary, it has an organic cause and typically starts several days before the onset of the menses and lasts till the end of the menses or beyond. So the management of primary dysmenorrhea, you exclude organic causes by history and examination, like and also you just give analgesics, NSAIDs, antipyretics, and opiates, except um, cases where they are contraindicated. So you can give antispasmodics like Nospa, Buscopan, and also combined oral contraceptives, um, menopause and ovulation. For all treatments, we use um, DNC, pre-sacral neurectomy, and childbirth too. For secondary dysmenorrhea, usually commences in adult life and often associated with pelvic inflammatory disease, endometriosis, fibroids, psychosexual problems. And the management of secondary dysmenorrhea, you confirm the organic cause by history and examination, and the investigations, you go on with ultrasonographic scan, laparoscopy, analgesics like NSAIDs, antipyretics, opiates, antispasmodics like Nospa, Buscopan. Could use combined oral contraceptive pills. That's for just an ovulation, just to prevent the pains. And also, we have definitive treatment for the cause.